lesions are often described based on the AHA-ACC lesion classification, which uses the degree of complications for each lesion treated. Type B or C describe lesions that are calcified or tortuous, and both characteristics increase the complexity of the lesion and the difficulty of performing revascularization. Studies have shown that over 75% of lesions can be classified in one of these two groups. We have a large toolbox of therapies to treat coronary calcification. All can have a role, and oftentimes they are used in conjunction with each other. Based on patient characteristics, comorbidities, hemodynamic stability, and intravascular imaging, calcium modification can be tailored for each lesion. Intravascular lithotripsy utilizes sonic pressure pulsatile waves delivered via balloon catheter to crack coronary calcium. Prior to any procedure, I always review the diagnostic angiograms to prepare myself and my team for any potential challenges. If I believe there are significant calcifications or tortuosity, I anticipate the need for support to assist with equipment delivery. For me, this means using a supportive axis, at least a 7 French system, and supportive guide. For the left system, it's generally an EBU, and for the right system, it's either a 3D right or an AL. Finally, I elect to use a supportive wire. First, I wire the lesion with any workhorse wire, and then using a microcatheter, I exchange it for a supportive wire. Again, for me, this is the wiggle wire. Despite these measures, on occasion, the intravascular lithotripsy balloon can be difficult to deliver to the lesion needing treatment, and there are several options to improve deliverability. First, you can prep the vessel proximal to the lesion more aggressively, which includes using a non-compliant balloon. I generally undersize my balloon by 1/4 to 1/2 millimeter and go to high pressures. Undersizing it helps to prevent perforation. Next, a guide extension catheter can be used. Depending on the size of the vessel, I choose my guide extension size. And there are multiple ways to deliver a guide extension, which include an inchworming technique or balloon assisting technique. I use most commonly the inchworming technique, which utilizes a 2.5 or 3 millimeter balloon, which is inflated directly distal to the guide extension. As it is deflated, the guide extension is advanced over the balloon, and these steps are repeated until the guide extension is at the lesion. The balloon assisting technique uses a similar sized balloon to act as a bumper as we deliver the guide extension. Lastly, an option to increase support to facilitate delivery of your lithotripsy balloon is to use an anchor balloon. Using a combination of these techniques, equipment can be safely delivered to lesions needing treatment, allowing adequate vessel preparation and calcium modification, resulting in better outcomes for our patients.